about the RAAS system. We're going to start by talking about the kidneys, their basic function, and then how that relates to blood pressure control and how it affects our lives as technicians. All right, so first off, what is the kidney? So the kidney is a bean-shaped organ. It's covered by perirenal fat and a connective tissue capsule. It's composed of a couple things. So first, we're going to start off, there's a portion of the kidney called the hilus, and that's an indented area on the medial side, and that's where the ureters and the blood vessels enter and leave the kidney. Okay. Then we have the renal pelvis. So this is in the center of the kidney. This is the urine collection chamber that forms the beginning of the ureter. And it's covered actually in transitional epithelium, so it allows for stretching without too much damage to the kidney. Then we have our calyces. These are cup-like extensions of the renal pelvis. We have the renal cortex, which is the outside portion of the kidney. And then the renal medulla is the inner portion of the kidney that's around the pelvis. There's obviously a couple more anatomy stuff of the kidney, but in pertaining to what we need to know right now, this is just what we're going to talk about. All right, so here's our beautiful picture of our kidney. This is what it looks like. So again, you can kind of see the outside layer, that's our little cortex. Within those, then we have our little pyramids, and that's then we have the medulla, which is that inside portion where those little pyramid shapes are. And then that middle portion, that white portion, is the renal pelvis that goes down and becomes a ureter. It comes out of that hilus, that middle portion there. It's a beautiful organ that does a million different things, and we're just going to talk about a couple of them. Oh, what is happening? Okay. So other than making urine, what does the kidney actually do? So, right, as we know, it produces urine to help facilitate elimination of metabolic waste from the body. What we also do is maintain homeostasis, so that's fluid regulation and our acid-base regulation. One of the most important things that it does is it produces three very important hormones. The first one is erythropoietin, and this is what stimulates the bone marrow to produce red blood cells. Next, we have calcitriol, and this is going to stimulate calcium absorption from the small intestines. And then the hormone that we're definitely going to delve into is renin, and that's involved in controlling our blood pressure. So very, very important, all three hormones. A couple other words to kind of remember, ADH, our antidiuretic hormone, or also known as vasopressin. This is made in the hypothalamus, and it's stored in the pituitary gland. And this is telling the kidneys to absorb more water, and it's also going to constrict our arterioles. It's going to help with blood pressure as well. On our blood work, obviously, you know, for our kidneys, we see creatinine and blood urea nitrogen, or BUN. Our creatinine is produced from normal muscle metabolism, whereas our BUN is synthesized by the liver from ammonia, and it's excreted by the kidneys. So the dreaded portion and the hardest part, at least for me when I was in school, is learning about the nephron. When you read about it and look at the pictures, which I'll have a couple for you guys, it just looks so intimidating. And it's crazy that this little thing that there's millions of in our kidneys, they're just responsible for so much, and they do such a great job at maintaining everything in our body. So first we're going to start off with the renal corpuscle. It's located in the cortex of the kidney, and this filters blood in the first stage of urine production. So fluid is filtered out of the blood, or what the fluid that's filtered out of the blood is called the glomerular filtrate. Okay, within the corpuscle, we have the glomerulus, which is a group of glomerular capillaries. Bowman's capsule is a double-walled capsule that surrounds the glomerulus, which that has two different types of layers. The parietal and the visceral layers. And the visceral layer is made of podocytes, which really look like fingers. They're like little extensions that create this permeable layer where fluid and other substances can pass through. Next, we have our proximal convoluted tubule, or PCT for short. This is responsible for reabsorption and secretion. And once our plasma or fluid flows through there, it becomes our tubular filtrate. Going down into the kidney, now located in the medulla, we have our loop of Henle. And then we're gonna make our way back up to our distal convoluted tubule, which thus leads to the collecting ducts. Now these carry the filtrate through the medulla to the calyces of the kidney and then to the pelvis. And obviously once we hit the pelvis, we're now urine. Okay, so this part plays an important role in urine volume. This is the primary site of vasopressin action, also regulates potassium and acid-base control. Okay, so very, very important. Couple more stuff about the nephron. There's a lot. We have the renal artery, which that branches off from the aorta and enters at the hilus. Remember that middle portion of the kidney where everything enters and leaves from. That renal artery is going to branch into or divide into a bunch of arterioles. So first we have the afferent glomerular arteriole, and that's going to carry blood into the glomerular capillaries of the renal corpuscle. We're going to have our glomerular capillaries, and this filters some plasma out of the blood, our glomerular filtrate. And at this point, it's still called arterial blood. So oxygen exchange hasn't happened. It's still oxygen-rich blood. Then we have the efferent glomerular arteriole. And this is divided into peritubular capillaries that surround the rest of the nephron. This is where oxygen transfer happens. And there's certain substances that are taken out of the tubular filtrate and it's put back into the blood. So this is reabsorption. And then there's other things that are secreted from the blood, and this is secretion. We have the peritubular capillaries, which eventually form into larger veins that eventually then become the renal vein. And again, just like the artery, the renal vein leaves the kidney at the hilus and joins the caudal vena cava. Interestingly, the blood in the renal veins is the purest in the body in regards to all the waste. It's the cleanest. Okay, so I remember this picture from school and I took a look at it and I was like, oh my gosh, I have no clue what I'm looking at. Again, it looks very, very intimidating. But once you start to recognize and realize the pathway of, how the fluid is moving, it can start to make sense. But as you can see, the top portion of the nephron is located in that renal cortex. So the top layer of the kidney and the bottom half of the nephron is in the renal medulla. So if you can imagine, this nephron is stretched along, the whole length, of the kidney. And again, there's millions of them. So I know that everyone should have received a copy of this, so you have the pictures at your disposal, so you can take a closer look. Again, a couple more pictures. I really love pictures. I'm a visual learner, so hopefully this helps everyone understand and kind of make more sense of the nephron. Again, it looks super scary, but it's honestly very beautiful at the same time. All right, and then one more. So again, this is our beautiful little kidney. Okay. So first, we're going to start off with filtration. So our glomerular capillaries contain fenestrations which assist in filtration. So this allows small molecules to pass through, whereas our larger molecules like protein and red blood cells should not and cannot pass, and that's going to stay in the blood. Obviously, if there's damage to these fenestrations, unfortunately, those molecules will eventually start to pass through. I'm sure everyone's heard of glomerular filtration rate, or GFR. And what that basically means is how fast the plasma is filtered as it's passed through the glomerulus. And so that depends on the rate of the blood or the plasma flow to the kidney. Next, we have reabsorption. So there's some molecules in the filtrate that's waste, and some want or need to be reabsorbed back into our system. And so that could be a variety of things. So we have our electrolytes, our sodium, potassium, chloride, calcium, magnesium, glucose, some amino acids, bicarb, and obviously water. Okay, this is going to happen between the tubules and the peritubular capillaries. Now, most of the reabsorption is going to happen in our proximal convoluted tubule, and then the other percentage, there's going to, it's going to happen in the loop of Henle, the distal convoluted tubule, and the collecting ducts. But again, the primary is in the proximal. Now we have our secretion. So many wastes can't be filtered in sufficient amounts in the glomerular capillaries. So we obviously have to do that elsewhere and make sure we get everything that we need. So we're going to have some tubular secretion, which that transfers substances from the peritubular capillaries to the interstitial fluid, to the tubular epithelial cells, and then into the tubular filtrate. This is mostly in the distal convoluted tubule. So usually we'll see this with our hydrogen, our potassium, and ammonia. Antibiotics like amoxicillin or clavamox or penicillins and sulfonamides are actually eliminated this way. So this is why they work fairly well when pets have UTIs. So a fun little tidbit. So after all of that, and you're probably still very confused and already forgetting the anatomy of the nephron, I have a little cheat sheet here on exactly what's happening during this process, okay? So first off, our blood is entering the glomerulus via the afferent glomerular arteriole, okay? High blood pressure in the glomerular capillaries are going to force some of the plasma, remember, minus our red blood cells and protein, those very large molecules, into the capsular space, into the Bowman's capsule. And this is now our glomerular filtrate. Then it moves into the proximal convoluted tubule, our PCT, and then it becomes tubular filtrate, okay? Whatever is left that, couldn't get filtrated out, our remainder of their plasma is going to leave the glomerulus via the efferent glomerular capillary and enter the peritubular capillary network around the nephron. So whatever's left over is going to get its chance to reabsorb or secrete as needed. While our tubular filtrate travels through the tubules, reabsorption is happening back into the peritubular capillaries. Our waste products secreted from the peritubular capillaries into the tubular filtrate as it travels through the tubules. And then it finally reaches the collecting duct, where now our filtrate is decreased in volume, because remember, we took everything that we needed and excreted what we didn't need. That filtrate's chemical composition is changed, and now we're ready to leave the kidney. So once again, once it enters the renal pelvis, it is now urine. There's nothing else we need to do with it. It's what we don't need. We're getting rid of it. Okay. Hopefully everybody is still with me here. I know that was a lot, but it's important to just kind of understand the basics of the kidney function. The main point of this talk here today is our RAAS, or our Renin-angiotensin-aldosterone system. It's stimulated by three factors. So first off, it's going to be stimulated by a fall in arterial blood pressure. And this is going to be detected by juxtaglomerular cells that are located in the afferent glomerular arterioles, okay? Another reason why this is going to be stimulated is a decrease in sodium. And that's going to be monitored by the macula densa in the distal convoluted tubule. And then lastly, the RAAS system is going to be stimulated by our sympathetic nervous system activity. Okay. So again, renin is going to promote, it's a hormone made by the kidney to help with blood pressure. And this is going to promote angiotensinogen, and that's made from the liver to release angiotensin 1. Okay. Angiotensin itself causes vasoconstriction and an increase in blood pressure. Aldosterone is actually secreted by the adrenal gland, and it's responsible for retaining sodium, secreting potassium, and increasing water retention. Okay, this is going to be stimulated by angiotensin 2 and hyperkalemia. And then we have ACE, or our angiotensin converting enzyme. This is going to convert our angiotensin 1 to angiotensin 2, which is our end product. Another picture again, just to kind of see how everything is working. So this picture here is depicting that the body is recognizing a low blood pressure. So the kidney is saying, or I should say the juxtaglomerular cells are saying, hey, we have a really low blood pressure. We have to do something about it. Our kidneys release renin. It meets up with circulating angiotensinogen that's made by the liver. They're going to meet up together and they're going to make angiotensin 1. Angiotensin 1 is going to go to the lungs where ACE is primarily produced. They're going to meet up together, convert into angiotensin 2. And then angiotensin 2 is going to tell the rest of the body what to do and everything on how we need, or what we need to do to get our blood pressure up. If we have, low sodium, that we need to, retain some more, hold on to some more water, again, vasoconstrict, release our aldosterone, and things like that. So really nice picture to kind of visualize the RAAS. Again, another picture just to kind of show you what it's doing. RAAS, or the final product, angiotensin 2, is going to have effects on the kidneys, the brain, the adrenal glands, and obviously our blood vessels. So this is all to help with our blood pressure, our sodium, and our sympathetic nervous system. All right. So again, just to compile everything that I just said, renin is released from the juxtaglomerular cells when stimulated. Angiotensinogen converts to angiotensin 1. Pulmonary blood releases ACE to convert angiotensin 1 to 2, which is our active form. This is going to stimulate aldosterone, corticotropin, and vasopressin release. We're going to have water and sodium retention, and our blood pressure is going to increase with vasoconstriction. So fairly simple, but super, super important. Okay. So obviously we have the system to normalize our blood pressure, right? But what if, we have the opposite? We have hypertension, so our blood pressure is way too low. Blood pressure is a product of the rate of blood flow produced by the heart. So this is your cardiac output times your resistance of blood vessels to your blood flow, okay? Our blood pressure is going to be increased by conditions that raise our cardiac output. So this is our increased heart rate, our increased stroke volume, and or, blood volume, or an increase in vascular resistance. When we have systemic hypertension, that's obviously a sustained elevation of arterial blood pressure. When obviously we're going to see damage, most commonly seen in the eyes, the brain, heart, and, the kidneys. There are obviously a lot of diseases that can cause hypertension, Cushing's, adrenal tumors. I feel like there are so many, almost any disease can cause hypertension. So it's never a wrong idea to check one on your patient. Now, the other thing is obviously, especially during anesthesia, we're always monitoring blood pressures. We always have these numbers of systolic, diastolic, but what does that actually mean? So our systolic is the pressure that the blood is exerting against the artery walls when the heart beats, whereas diastolic is the pressure when the heart is resting. Okay, so that makes it easier to kind of understand that. Our normal blood pressure ranges, now these are kind of average. Again, cats and dogs are slightly different. There can be some variances with different breeds and such, and obviously situational. But overall, we would prefer our systolic blood pressure to be around 80 to 140 millimeters of mercury, our diastolic 50 to 80, And then our mean or average is about 60 to 100. Now, related to this lecture, and we're talking about kidney disease, so most commonly we do see hypertension with kidney disease. With obviously there is some damage to the kidneys already, so they can be chronically hyponatremic, right? And remember, the RAAS system is stimulated, one of the reasons, by a low sodium, right? So if the kidneys are chronically detecting a low sodium, it's just going to keep starting up this system. Like, hey, we need to get our sodium up. You know, it's something's not right. We got to keep going. But again, with kidney disease, sometimes they can't really get that sodium to a normal level. So we're just going to be chronically stimulated over and over, which is going to then lead to then further damage to the kidneys. So we're going to have an increased hydrostatic pressure in the glomerulus. So we're going to increase our GFR. A sustained elevated pressure is going to cause damage to our glomerular filter, and it's going to force excess proteins to leak into the Bowman's capsule. So our big molecules that we don't want leaving, they're going to start pushing their way and causing damage and start to leave. We're going to see glomerular scarring and fibrosis, which is eventually going to render the glomerulus unable to function. And then again, this is where we're going to get our protein loss from our damaged tubular cells. There's going to be inefficient reabsorption. So we're going to see proteinuria on our urinalysis from our dogs and cats. Proteinuria, again, can occur independent to primary glomerular disease. Excuse me, that's something to talk about on a totally another day. But yeah, so one of the early signs of some kidney disease is proteinuria, so we want to watch out for that. How do we actually treat hypertension, though? I know that, you know, there's a couple medications that are common and that we're familiar with, but it also depends on the underlying disease process that's going on with that pet, whether it's heart disease, kidney disease, if they have an adrenal tumor, like a pheochromocytoma, that can cause blood pressure changes. For this purpose of this talk, we're just going to talk about the first 3 types of blood pressure medications as it pertains to the kidneys. But again, I listed all, you know, a couple other drugs that are used for blood pressure control, depending again on the disease process that we're trying to treat. First off, our ACE inhibitors. So I know for the longest time I was like, oh, ACE inhibitor. And then I realized what ACE was, and I was like, oh my gosh, it's all coming together. So our ACE inhibitor, our angiotensin converting enzyme, we're inhibiting that. So this is going to be our enalapril and benazepril drugs, okay? We are stopping RAAS at this point. Okay, we're going to try to inhibit ACE or angiotensin 1 from converting to 2 by ACE. It's not completely or complete, you know, it does inhibit, it doesn't completely stop all of the conversion. But it works by lowering their glomerular capillary pressure by decreasing the efferent glomerular resistance, and this is going to help reduce proteinuria. Side effects are going to include vomiting, diarrhea, hematochezia, anorexia, hypotension, and lethargy. I feel like pretty much more or less the same side effects for any drug. But again, we're going to continue to monitor our blood pressures and make changes as needed. We have our angiotensin receptor blocker, or ARB. I've heard people call it. We most commonly use a drug called telmisartan. This is going to inhibit angiotensin 2 receptor type 1. Angiotensin 2 has type 1 and type 2 receptors. For blood pressure and control, type 1 is what we're working on. Type 2 does other things. So this is where telmisartan is hitting at the type 1 receptor of angiotensin 2. So we're stopping at this area. It can be ineffective in complete RAS suppression due to prevalence of aldosterone breakthrough. It is also very common that we will need an ACE inhibitor as a second agent because angiotensin 2 can also be produced elsewhere, like in the heart. So it sometimes always doesn't work as a sole agent. Again, side effects can have vomiting, diarrhea, hyporexia, hypotension, mild anemia, worsening azotemia. So again, routine blood work and blood pressure checks to monitor these pets. So this drug is not directly working towards RAS, but it's used for hypertension in our hypertensive animals. This is our calcium channel blocker. This is amlodipine. It's commonly like our first step drug for high blood pressure. And what it does, it slows the movement of calcium into the cells of the heart and the blood vessel walls. So it's therefore making it easier for the heart to pump and widen those blood vessels to help lower the blood pressure. Again, it can be used alone or in combination with the other drugs. Again, just like all of the others, we need to watch for hypotension. Usually that's why we're going to start our dosing low and work our way up. The funny thing is, remember, RAS is going to be stimulated by a decrease in blood pressure. So for giving them a drug like amlodipine to help decrease their blood pressure, this is going to actually stimulate RAS. So we're trying to obviously decrease the blood pressure by giving this drug, but then the body is sensing, whoa, our blood pressure is going low. So it forces its way back up. So again, sometimes you do need a direct RAS blocker in conjunction with amlodipine. A side note, I'm sure a couple of you have seen weird gingival growths on dogs that you may notice that they're on amlodipine. This is called gingival hyperplasia. It is reversible if the drug is stopped. I'm unsure why it happens, but it's gross. I'm not sure it really does anything, but I'm sure it's unpleasing to the eye and for the owners as well. So how are we going to manage these pets with kidney disease, right? So we know that these pets need long-term follow-up. Chronic blood pressure checking, even if they seem okay, their blood pressure can change within a couple of months. So it's very important to check up on that, make sure that they're normal, make sure we're catching any changes if it's starting to trend high. We're going to do routine blood work and urine, not just chemistry panels. The BUN and creatinine are not the only important values here. We need a urine. We have to check their urine specific gravity and their protein levels, send out a urine protein creatinine ratio, make sure that we're not seeing progression with our kidney disease by seeing an increased level of protein. Renal diets can help, obviously, with the lower protein level. So less protein molecules that have to go through the kidney. Various medications, so supportive care, whether it's anti-nausea or anti-vomiting, appetite stimulants maybe if they need it. So pretty much just supportive medications to keep them feeling better if necessary. Again, monitoring our clinical signs, having an open dialogue with our clients, making sure that they let us know how their pet is doing at home. And then fluid therapy. There are times that we need to send home with some sub-Q fluids or teach the owners how to do that. Or if they need intermittent intravenous fluid diuresis in the hospital. Again, it all depends with how they're doing at home. So the big question is, and an important portion of kidney disease is, what if I have to anesthetize this pet? Okay. We already know that they're at a higher risk because they now have an underlying disease. It's already difficult for them to appropriately filtrate and absorb and secrete everything that they need to. Okay, so while they're under anesthesia, this is going to suppress autoregulation. So our RAAS is going to be suppressed. So we have to be there to help maintain their blood pressure for them. We're going to need to choose our fluid therapy and our drug choices. We have to make sure that we're keeping these pets warm. And again, obviously, monitoring their blood pressures closely. I know that the standard number of our mean arterial pressure is 60 millimeters of mercury. Me personally, I try to keep above 70. If I start seeing my pet hover between 65 to 70, I want to start intervening because I don't want to get to the point where my mean is 60 or below, and now my kidneys are not being perfused at all. I want to avoid that situation. Another helpful tip is to try to get a pre-anesthetic baseline of their blood pressure. If you have a pet who's chronically hypertensive, their kidneys are used to now a new normal. So say if, their normal mean arterial pressure is maybe 90, right? And then we put them under anesthesia, and if their mean is, 70, that's normal for us, right? But that's low for their kidneys. So we need to be mindful of that. And if situation allows us to, is to get a blood pressure prior to anesthesia so that we can keep their blood pressure while under anesthesia as close to their normal as possible. Our opioids can cause a transient oliguria by releasing vasopressin. Okay, it's going to retain fluids. Our benzodiazepines, so diazepine, midazolam, this is going to be excreted by our kidneys. So we're going to have a prolonged effect in animals with significant azotemia, okay? They're not going to be able to excrete the drug as well. In our pets with kidney disease, we're going to try to avoid acepromazine. I know it's a good drug and it has its uses, but this is going to cause vasodilation and it can decrease our blood pressure. So we have to remember that. Then we're going to avoid ketamine. Again, this is excreted by the kidneys, and ketamine can cause hypertension. So we have to be mindful of the situation, mindful of the procedure that they're receiving, and use our best discretion. If we have pets with chronic kidney disease on blood pressure medications or RAAS suppressing drugs, ideally, we would like them to be off of those drugs for at least 2 to 3 days prior to anesthesia. Definitely do not give it the morning of. So if we're already giving these drugs to help lower their blood pressure and we're putting them under anesthesia, we have risk of lowering their blood pressure even further. So we want to get these pets off of these drugs so that they can get their blood pressure back high again, so that if it does go low, we might still be in a normal range while under anesthesia. So we definitely want to try to remember, reviewing our patients' medical records prior to anesthesia, and make plans ahead of time again to stop any of these drugs for a few days prior to any procedure. So what if we don't do anything at all, right? Whether it's situational, so maybe the owner can't medicate or the pet is difficult or whatever the reason may be, we don't want to do anything, the owner doesn't want to treat, whatever. Obviously, again, as you know, sustained hypertension can cause multiple organ damage. So in regards to the eyes, we're going to have ocular edema, hemorrhage, retinal detachment. We see this a lot in cats, blindness, glaucoma, corneal ulcers. So you have an owner who calls who says that their cat suddenly can't see or is bumping into things. You're definitely going to check a blood pressure first. And again, these are all things that the owner should be warned about, if they decide to not pursue treatment or whatever the reasoning may be. We're going to have renal damage, right? So they're already PUPD, that can worsen. We're going to have tubular degeneration and fibrosis. And we're going to have obviously worsening of our kidney disease. In regards to the heart, so with the cardiac system, we're going to have some ventricular hypertrophy. They might develop a murmur or a gallop. Aortic dilation, capillary bed damage. They can have some remodeling of the heart. Neurologically, this is a big one that we see too. So they're going to have cranial edema. They're going to have increased intracranial pressure. I have seen severely azotemic pets be encephalopathic. So they don't look right. They're very lethargic. Maybe they're a little bit wobbly. Like they definitely look neurologic. They can have a stroke or a seizure or collapse episodes, all related to high blood pressure. And then the other last thing that high blood pressure can cause is epistaxis or nosebleeds. So it's an important thing to do for a pet, that before you recommend to go for a nasal workup, say for like a nasal tumor or rhinitis or something like that, it's a good idea to check their blood pressure if they're having epistaxis, just to make sure it's not a systemic effect that's causing that before saying, okay, yes, let's move on towards anesthesia and do a diagnostic procedure. I feel like I went through that fast, but that's everything. This is actually my own cat who was hospitalized last year. He had an acute kidney injury. So this is him looking so cute, and he's still with me, thank God, a year later. Can't believe that he made it through. But he was actually on a bunch of blood pressure medications and RAAS inhibiting drugs. So I would assume that that's what caused it. But that's my little cute boy. So I just want to, I guess, open the floor up now to any questions. I feel like I blew right through that.
That was perfect, Anya. So for our guests, if you have any questions, you can, if it's real quick and short, you can unmute and speak it. But the chat is also there. If you want to type something out, and I'll read them out for you, and Anya will respond. That lecture packed quite a punch. There was some really calorie dense slides on there.
It's very intense. The kidney is, actually, it was Dr. Pusho who told me when I was starting to do my research about the kidney. She was like, don't try to read in more into the kidney than you need to, because once you think you understand what's going on, you don't. It's very
I stand
complicated.
by that.
It's, oh my gosh, it's ridiculous. So I try to keep it as pertinent as possible and as simple, just to get the basic information needed. Is there a canine telmisartan or just RX human drug? So we use the human kind, but there's also, it's actually marketed for cats. It's in my picture. What was it called? Sementra. It's actually labeled for cats. It's a liquid telmisartan. But I mean, just because it says for cats, I mean, we use it for dogs too. It's just a liquid telmisartan. But yeah, so it can get a little pricey. So you just obviously have to speak with your owners, and obviously the doses that the doctors choose and things like that. But we do, just like a lot of other drugs too, we do use human formulations if the situation allows us to. I was just gonna ask if she can go through the whole thing again. Haha. Well, you have the, I know you should have gotten the email with the whole slide presentation, so feel free to reread it over and over. I know I have too, because I always get things confused or forget because there's just so much information. Advice for hypertension during anesthesia. Ugh, okay, let me think about that. Well, I know there are certain, it depends on the reason for the hypertension. So if they're, maybe a little bit dehydrated and the body's trying to work, sometimes we give fluid boluses. I know, in my personal experiences, if they become a little hypertensive, I'll assess the situation to see what the doctor is doing. Mostly we'll try to obviously adjust inhalants or give extra drugs if needed. One specific scenario that we were placing a subcutaneous ureteral bypass system, and during that procedure, you have to kind of place the 18-gauge catheter into the kidney. And one of our patients became severely hypertensive during it, and I would assume, that would happen, right? Because we're kind of jamming the kidney, right, and causing stimulation. And we gave, a little micro, like a 1 microgram per kilogram dose of dexdomitor. And that helped resolve it. But again, it's just all with assessing the situation. Usually it's like outside stimulation that you're gonna see some hypertension, that they're reacting, at least in my personal experience with that. Why isn't atenolol or other beta blockers used more in cats and dogs? Is not. Atenolol, I haven't used it I haven't seen the doctors use it primarily for like kidney disease, but more so in heart disease. Like my cat again is on it. But I think in regards to the kidneys, just the ACE inhibitors and the angiotensin receptor blockers are used. All the other drugs are more related to like the heart. And GoodRx, yeah, we use GoodRx too. All right. Sounds good. Thank you guys. I hope that you learned something. And again, if you are to remember one thing, I just want you to remember what RAAS is, because I know it's a lot of information here.